So, nearly 1/4 of transgender patients delay seeking care because of fear of discrimination. And one of the biggest reasons why delay seeking care is because of the anticipation of discrimination from providers. So, if you can imagine that this fourth of the room, you didn't go to the doctor, even if it was an emergency. And the reason why you didn't go was because a provider in this very room treated you or a friend so poorly in a previous visit that you vowed to never return. Now, 1/3 of trans patients end up educating our providers about trans health. And I'm all for patient empowerment and co-creating appointment goals, but in this case, I think that this is patient knowledge being relied on as expert instead of providers and researchers and medical education taking the time to invest and learn about and really invest in trans health in general. And historically, trans education is something that's really been lacking for a long time now. And that's had to do with lack of research, the stigma around being trans and being a provider who teaches trans people, and just inadequate and inadequate research just in trans health overall. But the trans community is deeply dynamic, and we've turned to ourselves for medical education. And we've been doing this on social media for a while now. We've been asking questions about our health, and the questions that we've been asking have been about our long-term health outcomes, and the questions and even the answers to them, or rather the answers and even the questions themselves they're not being answered in the doctor's room or in the literature in the past or present. So we have to ask what medical research is missing, because the most valuable data only exists in our community and it's tucked away. Trans patients have been filling in the gaps of our healthcare for a while now, but at what cost? We've had to accept care from people who aren't necessarily trained to treat us. And in 2017, that really still shouldn't be the case. And this is something that's been going on for a while. So I'll take you back to trans medical history. In 1939, there was a doctor by the name of George Voss, and he started experimenting with the use of testosterone for menstrual bleeding. Now, female-to-male trans man Michael Dillon heard about this, and so he went to see Dr. Voss, and he asked him if he would care for him. Now, Michael Dillon had a bit of background knowledge with testosterone, being a medical student himself, and so not a whole lot was known about the hormone at the time, but both of them recognized that Dillon needed treatment, and so Voss told Dillon, "You can have the hormones, and I wish you the best." So Michael Dillon was also a medical student in Ireland at the time, and he was rounding and shadowing surgeries during the day while having surgeries of his own in between academic terms. He underwent a 13-stage phalloplasty between the years 1946 and 1949. This is now typically a 1 to 3 stage procedure, but at the time, this was incredibly risky given it was a brand new procedure, and to even be a trans person open about seeking medical care and to be a provider who was willing to treat trans people. Now, soon after Michael Dillon's surgery, he met trans woman Roberta Cowell, and she wanted to have bottom surgery of her own, but providers refused to treat her. So, given his access to medical knowledge and his medical skills, he took the time to learn how to perform surgery on her, and he risked not getting his medical license. It's a lot of loyalty. And he ended up performing her orchiectomy for her, and then he introduced Roberta Cowell to his bottom surgeon, and the two of them ended up performing her vaginoplasty. Now, a trans man performed one of the first bottom surgeries on a trans woman. How incredible for trans health and for trans history. I don't know, for me, that's one of my favorite trans health facts. So Dr. Gillies and Dr. Foss, the two physicians who treated these two trans people, they weren't just altering trans bodies, but they were really saying for the first time that trans people deserve the same healthcare as anyone else, and to be trans didn't make you any different. It just meant that if you needed care, you needed care. And Michael Dillon documented all the care that he was receiving during this time in a book. And this type of self-documentation for community benefit is something that still happens in the trans community today, especially the trans masculine community on Instagram. So what people do is they share their preparation leading up to surgeries, their recovery, how they inject hormones, where they're going for care, which physicians people should go to, which institutions they should avoid. And what this also shows us is it shows who has access to care, who is being denied care, who feels lucky to receive any sort of care at all, and who's being completely pushed out altogether. Now, if we look at the numbers, 78% of trans people want to medically transition with hormones, but only 49% have. And 25% of trans people have had some form of surgery. And yet, so much of trans health research only focuses on surgery. And while the surgical numbers and the surgical data is very important to some of the trans community, it's not everything. Medical transition isn't for everyone. Now, my medical transition is really important to me. And when I last updated my advance directive, I made sure to include that I wanted to receive medical transition care until end of life. And for me, what that looks like is that I would want someone to help me do my weekly shot of testosterone until my very last breath, if that was something that I needed help with. And these are conversations that people within our community have, that our transitions are something that are so incredibly gender and life affirming, and that our quality of life has increased so much since we've been able to become our true authentic selves. And yet there's hardly any research on this topic. And what happens when trans people aren't involved in the research about our own community is that we end up having research on areas of curiosity instead of areas that are actually of interest and the most important to our community ourselves. So I have research about what my nipples look like, but I don't have research about what my liver is going to be like when I'm 80 because of these weekly shots of testosterone. Now, I'm concerned about if I'm going to get cancer because of these shots. And while I'm so happy that I've been able to medically transition, I don't have research to look at that relates to that medical transition. Yet, I can go and find research studies about the aesthetic appearance of nipples after surgery. Quite frankly, if I don't know if I could die from the hormones I'm taking, do I really care about these research studies on nipples? Now, there are only 3 longitudinal transgender health studies in existence. 3. The most recent study, and the only US study, it just wrapped up this year. It was out of Emory, and it worked with Kaiser and the VA, and it was funded by PCORI. It was a 5-year study, and it gave us a ton of new trans health information. And obviously we want as much trans health information as possible because we have this huge dearth of information. But it was only a 5-year study, right? So can we really say that a 5-year study is enough of a long-term study to tell me what my long-term health outcomes are going to be like when I'm 80 years old? And it was only 2 years ago that the first ever NIH-sponsored research study about trans youth who are taking hormone blockers and cross-sex hormones started. Just 2 years ago. How many studies do we have on kids with ADHD or adults with diabetes? We have thousands, tens of thousands. And that's not to compare being transgender to diseases, because being trans is not a disease, but just goes to show that I can count the number of studies on my long-term health outcomes on one hand, 3, and we can easily count all the hands and toes of everyone in this entire room for probably just a study on one of those in the past couple of months, or maybe even the past month. And a recent NIH study found that there are only 43 studies in existence on transgender health topics. 43. If you remove HIV and AIDS studies from there and other sexual health topics, that number goes down to 14. Just 14. There's only one trans health study assessing the risk of hormone-related cancers. One. And there are 0 funded studies focused on metabolic and cardiovascular diseases that may be linked to hormone use. 0. That doesn't make any sense to me. Now, when we don't involve trans people in the research process, and we end up having hardly any research on trans health, we continue to have these myths spread as truth. And when we have myths spread as truth, whether that's from provider to provider, patient to patient, then we end up continuing to believe things that just aren't true. You do not need to get a hysterectomy within 5 years of starting testosterone. Testosterone does not act as birth control. And yet these are things that patients are spreading amongst the trans community. These are things that providers are still telling patients and referring patients to go and have surgeries to do. And in doing so, this also makes members of the trans community think that inherently by medically transitioning that we're causing harms to ourselves when we just don't know that that's true. Now, if we are going to do more trans research, then that also means trans people need to be willing to participate in trans health studies. So I've been working on addressing this by a series called Transgender Health Patients and Providers. And what it does is it brings together people on both sides of the aisles, patients and providers, and it has people sharing their voices who are knowledgeable about or want to learn more about trans health. And patients share their experiences, whether they're positive, negative, somewhere in between, and providers share what type of research they're conducting or research that's already happened, whether they're trying to recruit patients. And we're able to build a connection in a community so that we can learn from each other. And this is going on both nationally, internationally, and it's something that's been going pretty well so far. Now, we know that with the bare minimum knowledge we have right now, we need to do something to change that. And whether that's patient empowerment, whether that's provider empowerment, something else needs to change. Because if we don't, if we have patients waiting in silence, then we also have providers assuming what we want or need. And what that does, that has the potential for causing harm. It's estimated that we have around 1.4 million people who identify as trans in the US alone. And how we found that number, we excluded non-binary people in the research study itself. So we know that there are probably even more people than that. And still, we have sample sizes on trans health that have less than a dozen people in them. So I know we can do better than that. We also know that 97% of medical residents believe that trans medical issues are relevant to their practice. And we know from a recent statement they put out from the American Medical Association that trans people should be able to serve in the military and that trans medical issues are something that deserve care. But even with all this vocal support, the average amount of time spent training medical students in LGBTQIA health is still only 5 hours, with a third of schools spending 0 hours. So we can't just talk about how we support trans people, and we can't just talk about how trans health needs to improve. We have to actually do something. What we need you to do is we need you to invest your time in trans patients. We need you to invest your research dollars or institutional support in actually training. Because if we don't do that, then we just continue to cause harm. Trans patients need providers who know what our expected health outcomes are. And we need research that knows what our bottom line is going to look like down the road. I want to know if I'm going to have cancer again, because I've already had a brain tumor, when I'm 80 years old. I need to know if my weekly shots of testosterone are causing harm, or if we can move from this pervasive uncertainty and towards better evidence-based practice. Now, we have some time for questions. Liz?
So I know you really well. And what I just heard is shocking me to hear the numbers are so low and the amount of research and what the long-term outcomes are. And I understand that there are barriers and why this discussion has never come up. Are you putting out a call to action? I mean, I hear this, it sounds like a call to action. Like, I don't know. I'm really interested from the providers in the audience if they've heard these statistics and numbers and what is being done about this. So thank you for sharing that story.
Yeah, I think I'd be curious to hear from the other people in the room as well, if they've heard these numbers before, if they're familiar with them, if if there's any research going on in their institutions. Just because there's only 3 longitudinal health studies on my community. I think if anyone else in the room, so we're all people. Some of us have diabetes, some of us might have had cancer, some of us have cystic fibrosis, some of us, have a variety of other conditions. But with that, if you can imagine, you go to the doctor and you fill your prescription, and you know that you received this medication because it was, cleared by the FDA for saying that it was something that was safe and it was proved to treat you, or that it was going to give you a cure or put you in remission, and that those side effects were certainly cleared and okay to treat. Well, when I go to the pharmacy and I pick up my testosterone, I take that knowing that it's something that I need to do, but it's also something that I don't know what its side effects are, and I don't know what it's doing. But this is something that I have to do, right? And so I want you all to kind of think about if that was something that you were doing. Every week you were taking a medication, you were injecting it into your body, and you didn't really know what the impact of that was. What do you kind of think that that psychological safety? I know we've talked a lot about psychological safety this weekend. Do you think that would give you a lot of psychological safety, or do you think that would give you some stress? I think I see someone else standing in the back with the question, maybe.
Thanks. I just was wondering, as you've pointed out, there's little research already being performed, and we're increasingly using electronic health records for research, but yet when I talk to trans people, they find they often can't even answer the intake questions about sex and gender just in the way the data is being presented. So are there any efforts going on to restructure electronic health records?
Yeah, and I think out of Johns Hopkins, they're just reopening their gender clinic now. They were one of the first places to perform gender affirming surgeries, and they shut down, and now they're just reopening again. But there was a study, there's a research study that they did with Pecori, and I can't remember the name of it off the top of my head, but I can look it up for you. And they published all the information this spring, but it looked at how willing are patients to disclose their sexual orientation or gender identity with providers versus the assumption versus the provider assumption that people won't want to. And some of that also looked at the intake forms. And if the intake form, I think one of the best practices and ways to do that is if you have, what is your sex, what was your sex on your original birth certificate, or what was your sex assigned at birth versus what is your gender identity? Because while in day-to-day that doesn't matter, with your medical history that does matter in terms of, do you need to go to the gynecologist? Do you need to go and have a prostate exam? Some anatomical things matter for medical history, but in terms of, if you go to the doctor and you identify as non-binary, or if you go to the doctor and you're trans and you don't see yourself reflected on that intake form, it's really hard to even think about going back to the doctor after that first visit. And then the community just continues to turn inwards and not trust research. And so part of that means that trans people need to be involved in coming up with the research questions, in designing the research, in dispersing that in data collection, and also in analyzing the results as well, because no one knows trans people better than trans people, right? So we know what questions that we wouldn't want to be asked. We know what's offensive. We also know the questions that the trans community really wants the answers to. I think there's a question over here.
So I have found that where there is money, researchers come. So I wonder if there are grant funding organizations with money that could be driving researchers to do more work in this area. And maybe that is, rather than going to it sounds like the clinicians want to know more, they realize it's relevant. The the data and the research isn't there. So like maybe it's about the patients partnering with the grant funding organizations, and then the rest kind of falls into place a
Right.
little more.
Yeah. So Pcori has really kind of started to jump on board and really definitely, they were predominantly the predominant funder for the big Emory study, the 5-year study. So Pcori is a huge supporter in trans health research right now. But it looks like I'm out of time. So thank you all for coming. If anyone else has any questions, I'd be happy to talk to you for the rest of the day, the rest of the weekend. So thank you.